Paper number 2, drug-eluting stents are associated with good midterm outcomes for the treatment of failing infrainguinal bypass grafts, to be presented by Dr. Stanko and colleagues from Johns Hopkins.
Thank you. My name is David Stanko. I'm a surgery resident at Johns Hopkins. I'm planning on going into vascular surgery in a couple years. I'd like to start by thanking VESS and the group for organizing this conference and for having us here. These are our disclosures. The most important disclosure is the final one. The whole point of this talk is to discuss off-label applications of coronary artery stents for the treatment of infrainguinal bypass stenosis, which is off-label. So the background is that we previously published a short-term patency data for using drug-eluting stents for failing infrainguinal bypass graft stenosis in the Journal of Vascular Surgery in 2018. We got pretty good feedback from this, and we set out to assess the midterm, basically an update to this with midterm patency data, as well as to add an additional treatment modality. So this is an important slide for therapy selection so that you can relate this to your patient population and your practice patterns. At Hopkins, essentially these patients are coming in, they're getting their index operation for their treatment of an individual stenosis that's identified, and they get their angioplasty or whatever from the physician, and it's the physician's discretion. So these patients are not randomized, and this is a single center. And then if they represent with a recurrent stenosis in the same location, then at Hopkins they become a candidate for using an everolimus drug-eluting stent or coronary artery stent for the treatment of that recurrent lesion. And then at Hopkins we place all patients on dual antiplatelet therapy after their index endovascular procedure. This was from the prior report in the Journal of Vascular Surgery. We showed that the primary patency for drug-eluting stents was superior to the other modalities, percutaneous cutting balloon and percutaneous transluminal angioplasty, out to 24 months. This doesn't point, but out to 2 years. And that was statistically significant. And this is sort of unexpected if you think about, again, selection bias like in the previous talk. You would think that if you think about the lesions that are getting treated with the drug-eluting stents, they're the lesions that have already failed and are already being retreated. So you would think that if these patients have some worse biology or if the lesion itself is somehow more recalcitrant and more likely to stenose, that these patients should actually probably do worse than the other treatment modalities. So this was an interesting finding. And we also then published the primary assisted patency data, the secondary patency, and the limb salvage data, which showed no difference in outcomes amongst these treatment modalities. So here we concluded that these drug-eluting stents were considered safe and efficacious as an endovascular technique for treating these infrainguinal bypass stenoses, and they sort of became second-line therapy at Johns Hopkins, again with some physician discretion. So the aim in patient inclusion for this study was to update that prior analysis with midterm data and to add drug-coated balloons to the prior 3 treatment groups. We had 73 patients with 154 discrete lesions. The average age was 65. 55% were male, 48% were black. 82% originally presented with chronic limb-threatening ischemia, and over half of them had bypass anastomosis that were distal. The distal target was either tibial or pedal. This is important. The median follow-up was 24 months, so basically we're adding these patients to the prior report. So we have an IQR from 8.6 to 48.4 months. So those patients that we've been following since the prior publication have now gone out to 5 years or more. But the addition of the DCB group obviously has less, because historically at Hopkins we weren't doing as many of those. Importantly, there was no difference in the bypass configurations, the conduit choice, or the stenosis locations across these 4 treatment modalities. This is the primary patency data for these 4 treatment groups with the DCB, the drug-eluting stents, the PTA, and the PCB out to 20 months. Here, there's no difference in treatment outcomes across the primary patency, with drug-eluting stents having 55% primary patency out to 20 months. However, when we start to look at the primary assisted patency, so I should say I'm starting here by adding the 4th group to the prior analysis. Here with the primary assisted patency, we see that drug-eluting stents are now outperforming the other 3 treatment modalities out to 20 months, with a primary assisted patency of 82%. Secondary patency eluting stents are outperforming the other 3 treatment modalities, similar to primary assisted patency, and at 20 months, the secondary patency is 87%. So the result summary here is that at 12 months, I should say here, in any of these 4 groups, you can see that at about the 12-month cutoff, there's really no difference, and that emerges as you get to 18 and 24 months. So there's no difference really between these treatment modalities at 12 months, but at 18 and 24 months, a statistically significant difference emerges in the primary assisted patency and the secondary patency, with drug-eluting stents being the best, followed by PCB, PTA, and DCB. And this is sort of a summary slide showing how drug-eluting stents are performing out to 20 months. The limitations here are important because there was 4 treatment therapy groups, so we added a 4th group, so we lost some power in the sense that we only have one institution with only 154 lesions. And we submitted this abstract like everyone else in August or so we do have 6 additional months which we'll add. And the other important thing is the selection bias, which we already discussed. However, again, we would think that the selection bias should be against us in the sense that we're only using these drug-eluting stents on the recalcitrant lesions. So they should, if we would think, be more likely to fail. This is a sort of sneak peek, though, at the other prong of the study, which is that if we look out to 35 months, we see that drug-eluting stents with respect to primary patency, again, looking at only these 3 groups that were initially published in the Journal of Vascular Surgery, the drug-eluting stents are outperforming the other 2 out of 35 months, which reinforces the sort of the prior work that was shown. So the conclusion here is that drug-eluting stents are associated with superior patency rates in infrainguinal bypass stenosis, particularly in these recalcitrant lesions, and it could be considered a reasonable treatment modality for failing infrainguinal bypass stenoses at your institution. And we need randomized control trials to compare treatment modalities further. Thank you.
Thank you. This paper is open for discussion.
Hey there. Thank you very much. Ruth Bush, Houston, Texas. So a couple of comments for you. So your conclusion was that the drug-eluting stents offer superior outcomes. However, your title's pretty milquetoast, that they offer good midterm. As someone who's been an editor on many journals, I would have you make sure that your title, your abstract conclusions, and the conclusions of your data really want to lure your reader in, because that's what they're going to read, because that's what you presented in your data and your conclusions. So congratulations, make the title stand out. And then my second comment is on the Kaplan-Meyer curves. They're pretty stepwise at the very end. Could you talk about what your numbers, your censored numbers were? How many of those cases of drug-eluting stents did you actually have followed out at the different time points compared to the other groups? Thank you.
Great, thank you for those comments. I appreciate your comment on our title and our conclusions, and we'll keep that in mind. In terms of the Kaplan-Meyer curves, there was no difference in the treatment therapy groups in terms of the censoring data or loss to follow-up at the assessed life table points at 12, 18, 24 months. Or we sort of presented the 20-month data as a sort of middle ground for conservative conclusions with the treatment. Basically, the follow-up was limited if you look at all 4 groups because that one individual group had less follow-up than the other 3. So instead of making sort of grandiose conclusions about all 4 groups, we restrained our sort of 8-minute presentation here to those 4 groups. And that's also why we were somewhat conservative in our conclusions and our title. But yeah, the Kaplan-Meyer cutoffs are somewhat stepwise, but they were consistent across 4 groups. Thank you.
On the right there.
Oh.
Hi, Sam Tiagi from University of Kentucky, Lexington, Kentucky. Great project, I really like it. One interesting thing is each one of us in vascular, when we approach PAD, we all have our own different algorithms. So when I was looking at this, I didn't really see the algorithm that I use on there, which often, especially in a vein bypass that has a stenosis, is I use a cutting balloon and a drug-coated balloon. So what did you do? How did you parse out the patients that had combination therapy? And I think you talked about it a little bit, but maybe putting up a pictorial algorithm for how you guys approach this might be good. So.
Thank you. Yes, those are great points, and we've actually discussed some of that. In terms of the treatment algorithms, those are surgeon dependent, and we have 5 or 6 surgeons that are doing, basically they see the patient, they make a decision based on the angiogram or whatever they think clinically. They will typically start that way, but they may not, and then like the general sort of overarching view is that after their first index operation, when they represent, then they become a candidate for the drug-eluting stent. But sometimes they'll get 2 or 3 or 4 interventions before there. And I agree, we were actually discussing doing a Sankey diagram to kind of show how people flow through their different interventions. And we hope to have that in the paper as well.
Yeah, I think that would make it a little bit more clear.
Thank you.
I got a quick question. Right here. Were most of the bypasses prosthetic or were they autologous?
Yeah, they're vein.
They're all vein. My question is, do you know which area of the bypass was treated with which modality? Because you can envision that if you have a bypass coming off the common femoral, somebody might be reluctant to put a stent in that area, thereby, right? So you'd probably cutting balloon, DCB it, so the difference in the location might actually make a difference as to what your outcomes are.
Yeah, so there was no difference in the type of the distal target or in the location of the stenosis. So the patients might have, for example, a stenosis that's on the distal anastomosis, and then present later with a stenosis somewhere else, and we would consider that two distinct stenoses. And then they can be treated according to however the surgeon intervenes. Does that?
It does, but my question is, if you had a common femoral, like if the bypass is coming off the common femoral, you're not going to stent that, correct?
Right.
You're probably going to balloon that. Did you notice a difference in patency when you treated the area differently? So if you treated the bypass coming off the proximal anastomosis as the common femoral versus the SFA?
So I would have to double check to be sure, but I'm fairly certain there was no difference since maybe Dr. Hicks has a thought here.
David's giving the technical questions a good shot, but he's a third-year resident, so he hasn't done too many of these. So the typical paradigm, to answer the previous question, is they come in, they get whatever we think, but they're not usually getting PCB or DCB together. We used to use a lot of percutaneous cutting balloon, and then after that original publication, which showed that it had pretty poor outcomes, we've shied away from it and introduced DCB. So that's sort of the background of the study. Most of these anastomosis stenoses, like 80% of them are distal. So almost all of these targets are distal targets. Some of them are intra-bypass targets, so at the spliced vein or something like that, but very few proximal anastomosis problems. So we're not probably seeing that at all.
Thank you.
Okay, final short question. Vic.
Well, I had the same question, but I guess, is there a routine where you do not put a stent in a bypass? Maybe that would be more educational about, for us, if we're thinking about this as the tool to use. Are there places where it is a problem or you don't think it should be used?
Just the distal, correct? Just tibial? Yeah.
Okay, thank you.
All right, thank you.